Yeah, live Nishan. Vicky, can we start?
Yeah, you can talk. You can start now.
Good evening, all the participants. So today we have a very special guest, Dr. Meera Ragavan, on our Shield Connect page, and with furthermore discussion, let me give a quick intro for today's topic. So let me share the screen. So today our speaker is Dr. Meera Ragavan. Ma'am is a senior consultant in Apollo Hospital from Chennai. So participants, if you have any query in the end of this session, we can have a Q&A. So let me hand over the session to ma'am. Ma'am, I welcome you on our platform.
Thank you.
So I hand over the session to you.
Thank you.
Yes,
I'll share my screen.
yes ma'am.
Yeah. Today is a very interesting topic, which many of the time is confused with either UTI or some other problem, when actually it is a complete enigma for people who have not come across this presentation, or probably frequently come across, yet are puzzled why this patient is coming back again and again, even though the treatment has been instituted. This is what is called the interstitial cystitis stroke bladder pain syndrome. It encompasses an umbrella of symptom complex where patient experiences a triad of symptoms, mainly pain, frequency, and urgency of urination. So when did all start? This was Aunt Minnie's description of interstitial cystitis. We've all met patients who suffer chronically from their bladder, distressed, constantly having to urinate often, day and night, suffering pains every time they void. Miserable patients are unhappy and influence the general state of health physically, socially, psychologically, which is very true. That brings us to understanding why this condition is so distressing. The term ICBPS has a very strict definition, and according to the Global Interstitial Bladder Pain Society, it should be lasting at least for 6 weeks. Chronic symptoms of pain emanating from the bladder area and or the pelvis. There should be at least urinary urgency and or frequency, and no other identifiable cause should be present. This is, if there is an ulcer, then typically fits into interstitial cystitis, whereas if there is no ulceration or features, it shifts into bladder pain syndrome. So the European Society for Study of Interstitial Cystitis, according to the classification, where based on whether cystoscopy with hydrodistension was done. And they found that in majority of the cases, Hunner's lesion might be present, or interstitial cystitis with glomerulations can be present. This is how the bladder appears with interstitial cystitis or with Hunner's lesion. The one on the right shows a pale area here, which is in the form of a star, what we call a stellate puckered scar with hyperemia at the edges. This is classic of a Hunner's lesion. These are petechial hemorrhages, glomerulations with dilated engorged vessels. The bladder literally looks very angry. Sometimes you'd be worried to look at the bladder because grade 4 interstitial cystitis can look as if the bladder has been torn with multiple places with a razor blade. That's how it, dangerously can appear to the cystoscopic finding. This is the inflammatory infiltrate with histiocytes and macrophages, which appear on histology picture, though not specific for interstitial cystitis. In other words, it is a cystoscopic diagnosis, and you do not need a histological confirmation of the same. However, a biopsy is prudent to rule out GUTB as well as carcinoma in situ, especially in a country like ours where TB is endemic. 10% of the cases can present with bladder pain syndrome. So they're not all UTI. Mostly women, 90% are women, and the median occurring age is usually the reproductive peak between 35 and 40. The reason for this is there is a lot of crosstalk and networking between the brain, the gut, or the bowel, and the bladder, what we call the crosstalk between the three Bs: brain, bowel, and bladder. So when there is an insult, either due to a pelvic floor problem, an autoimmune disorder, an infection like a UTI itself can flare up, an interstitial cystitis, a neurogenic inflammation, say for example, a surgery done inside the bladder, or an endometriosis, or radiation can trigger a similar picture. Trauma and overdistension all cause damage to the epithelium. That causes relief of a particular protein called APF and leakage into the interstitium, which triggers off an inflammatory process by mast cell activation. Because of the mast cell activation, it causes the pain fibers or the C fiber activation, which then travels up to the brain and causes severe progressive pain sensitization. If left all alone for a long time, can lead on to centralization or central sensitization of the pain itself. So recurrent pelvic pain or discomfort, mainly pressure, burning, and throbbing, at least 6 weeks duration. Typically, the patient will tell that I'm comfortable only after I empty my bladder. When the bladder is filling, it causes an unpleasant sensation. It is very painful, and I get a bit of relief on emptying the bladder. So ask specifically whether the pain is during filling of the bladder or during discharge of the urine. If it is discharge of the urine which causes, that is urethral in nature, whereas bladder filling causing pain is usually a condition due to bladder pain syndrome or interstitial cystitis. It is almost always associated with urinary frequency and urgency. That is why it is called the PUF triad syndrome, which pain for pain, U for urgency, and F for frequency. And the impact of this particular problem is analyzed or studied using the PUF questionnaire. So you might be wondering that with the PUF syndrome or the PBS, there can be an inter or overlap with overactive bladder as well. Yes, because they're present with urgency, urge-related frequency, and incontinence as well. Because 14% incidence of urodynamic detrus or overactivity is seen in IC patient because of a sensitive bladder which irritates the bladder. So with regards to presentation, very, very rare that these patients will leak. In fact, they can have difficulty in emptying the bladder completely because the pelvic floor goes into spasm. Other symptoms can be dyspareunia and pelvic pain. Other associations, very, very important in taking a proper clinical history in terms of whether they suffer from other allergies like asthma, eczema, skin allergies, allergic tendencies, irritable bowel syndrome, non-specific fibromyalgia, autoimmune disorders, anxiety and depression, and affective disorders as well. So there is no consensus on minimum or optimal workup. No shortcut to detailed history and examination. Right from the patient entering the consultation cubicle, we need to make sure we are having an eye on specific details as to exclude other causes. What all to exclude? We need to exclude endometriosis, other inflammatory condition, carcinoma in situ, and of course GUTB. The tools which are available for us are very simple: a detailed history and examination, a questionnaire pertaining to interstitial cystitis and PUF syndrome, a simple urine analysis. If the urine analysis shows pus cells, it's most likely UTI. If the urine analysis shows pus cells, but there is no infection with bacteria picked up on the culture, it could be because of an empirical antibiotic treatment. Recurrent pyuria with no culture picking up or a sterile urine suggest it could be GUTB. If there is hematuria with associated pyuria, we need to rule out GUTB. It could be due to cystitis, which is complicated as well. At the same time, if it is only RBCs or microscopic hematuria with no evidence of culture positivity of pus cells, it could point out to a bladder cancer or carcinoma in situ. So a simple urine routine on microscopy can help us delineate a myriad of conditions, which of course should not be missed while managing the patient with lower urinary tract symptoms. Imaging of the upper tract is important if the patient has hematuria, if the patient has recurrent pyuria, if the patient has a complicated cystitis, patient has a voiding dysfunction, or the presence of previous radiation. All these matter much because secondary bladder cancer post pelvic radiation is also a known entity, especially in the background of tobacco usage. Imaging is very, very crucial. Always do a urine cytology. If in doubt, that will pick up any malignant cells in the urine. Urodynamics is not a common test which is done in the management of interstitial cystitis. Imagine this patient with the presentation itself has severe pain on bladder filling. When we are filling the bladder during the urodynamic procedure, it can be very unpleasant and can trigger off severe pain. So we do not recommend urodynamics as a routine investigation for these patients. However, in the presence of hematuria, or when you're suspecting GUTB, or when you're suspecting carcinoma in situ, it is very important to perform cystoscopy as well as for therapeutic interventions for this particular problem. With regards to questionnaires, these are not for diagnosis, but helps us assess how severe is the issue and what is the prognosis for this patient. So we have the O'Leary Sant symptom index. As I mentioned, the pelvic pain urgency and frequency scale, or the PUF scale, and the genitourinary pain index. And there are basically questions related to bladder, pelvic pain, and sexual dysfunction. This is about urine analysis, always a must for microscopy and bacterial culture. Urine cytology for malignant cells. Urine for AFP must be first morning and not overnight collection. Nanobacterial culture are also investigational and anti-proliferative factor, which I mentioned, the APF. These are only in research setting and not routinely done for the diagnosis or for the exclusion of the diagnosis of interstitial cystitis. Ultrasonography only as an extension of the clinical examination, not as a substitute for the same, because when you clinically examine a patient with bladder pain syndrome, I will go through the steps of what all you can pick up. These patients are extremely anxious. They will not be able to rest their bottom on the couch. They will have a taut pelvic floor tone. So when you do a vaginal examination, you probably need to insert only one finger. Sometimes you have to inspect the vulva and the perineum carefully to look for any fissure, any abrasions, any redness, because vulvodynia can also be present in these patients. And always find out if there are any trigger points which cause pelvic floor spasm or any pains, and that can be done using a cotton tip to find out which areas are sensitive and do a pictorial mapping of those trigger points. Always do a very gentle vaginal examination. Palpate the posterior vaginal wall right up to the pelvic wall, lateral wall, to look for any myofascial bands. This is a very, very important examination finding. You can find taut myofascial bands in patients presenting with interstitial cystitis and bladder pain syndrome. They're extremely tender and they're spasmodic in nature. Also palpate the bladder base, which is the anterior vaginal wall. Look at the urethra for any inflammation, and also gently press on the bladder wall. If the patient is having extreme tenderness, that could be a pointer to interstitial cystitis or bladder pain syndrome. Very, very rarely we will need a CT MRI. Do not proceed to do a immediate speculum examination for these patients. They will not be able to tolerate it at all. In fact, they will not be even able to tolerate a digital examination. So many of these patients are unnecessarily treated for vaginismus or sent for psychosexual counseling. Of course, that is part of it, but vaginismus is not the diagnosis of the patient, or they're treated for repeated antifungal treatments, considering that it could be candidial vaginitis or things like that. Many of them undergo unnecessary, unindicated hysterectomy, saying that this could be emanating from the uterus. That is also not correctly indicated. Urodynamics, again, as I mentioned, is not routinely indicated in pure bladder pain syndrome patients. Possible indications could be because of detritus or overactivity, and when you have a voiding phase dysfunction. When do you have voiding phase dysfunction? Because either of the pelvic floor spasm, which can happen in these patients due to central sensitization, or when the grade 4 interstitial cystitis happens and the bladder is extremely scarred and fibrotic and not able to contract well, loses its contractility or causing dysfunctional contraction, then you develop voiding phase dysfunction with retention. This is a 55-year-old patient with severe perineal pain associated with voiding for 3 years, lump-like feeling in the perineum, and hysterectomy 1 year back. See, she's got increasing in the pressures and pain associated with the filling aspect of the bladder. And she's undergone an unnecessary hysterectomy without any reason for bladder pain syndrome. When we proceed to do, because we're suspecting a non-compliant bladder, a bladder is not supposed to increase its pressure when filling. And if it is doing so, it is already showing features of scarring. It is becoming non-compliant. It can become a stiffened bladder and cause back pressure into the kidneys. So any pressure mounting inside the bladder during filling phase of more than 25 centimeters of water will be a threat to the upper tract, and that is why we need to make sure we do these investigations. So on cystoscopy, classically you're able to see this Hunner's ulcer. This is a stellate shaped scarring, pale area which has got hyperemia all around. If you fulgurate this Hunner's ulcer or resect it, that will be therapeutic for this patient. If you do not treat this Hunner's ulcer, the patient will come back to you with repeated symptoms. The other zones of the bladder also show glomerulation, dilated venous pattern, and congestion. So patient has been having straining, urgency, and suprapubic pain on full bladder, frequency of urination, recurrent UTI-like symptoms, not UTI, blood in urine, and severe pelvic pain on postponing urination. Classic bladder pain syndrome, pelvic floor tone increased, no tender points, urine cytology, urine culture negative, partial benefit with gabapentin and tizanidine. This is basically central sensitizers, which act as central analgesics for these patients. So typically there is increase in the pressure in the bladder, and this is what is happening on bladder filling. See the cystoscopic finding, multiple glomerulations and petechial hemorrhages, which is pan-global, and this stellate scar with hyperemia all around, which is like as if there is a puckering inside the bladder, as if somebody has burnt the bladder. It presents like what you see sometimes in early endometriosis or treated endometriosis at laparoscopy. This is not endometriosis of the bladder. This is Hunner's lesion. Interestingly, 60% of patients with bladder pain syndrome can have pelvic endometriosis as well. And 40% of endometriosis patients with bladder symptoms can have associated bladder pain syndrome. So there is always a debate. If we do not take a proper history, we might miss the coexistence of bladder pain syndrome, or we might even miss the proper diagnosis of endometriosis if the patient is presenting with lower urinary tract symptoms. So whenever patients present with pelvic pain, always take a detailed bladder related history. Whenever patient present with recurrent UTI-like symptoms, always take a detailed history regarding pelvic pain as well, especially pointers towards endometriosis. The 5 Ds: dysmenorrhea, dyspareunia, dysuria, dyschezia, as well as dysfunctional voiding. So it's very, very important to know that endometriosis coexists with bladder pain syndrome in a significant proportion of patients. And if you're planning treatment, we might need to do a concurrent laparoscopy and cystoscopy for these patients to make our diagnosis perfect and to give the maximum benefit of doubt to the patient. So when do you do a cystoscopy? As we already discussed, whenever there is pus which is persistent, microhematuria of any type, any kind, any magnitude needs a investigation. Severe symptoms, particularly small fixed capacity of bladder diarrhea and scalding pain. A smoker or even a passive smoker whose spouse is smoking needs the cystoscopy, and if the patient is not responding to initial therapy. Never perform a cystoscopy under local anesthesia if your primary aim is to investigate bladder pain syndrome, because the patient has an extreme sensitivity to anything touching the urethra and can be very, very uncomfortable. So what you're looking under anesthesia are glomerulation or Hunner's lesion, as I showed earlier, and use the same sitting to do a biopsy, to do a fulguration, and do a hydrodistension. If nothing is there, do a redistension. And on redistension, if these things appear, then go ahead with the hydrodistension. So an in and out quick cystoscopy is no good while investigating a patient with interstitial cystitis. Therapeutic distension is done with the normal saline 1 liter bottle, kept at a height of at least 1 meter from the ground level, from the patient level. And I usually do the distension not more than for 2 minutes, because sometimes the bladder can give way. It is known that when you distend the bladder for more than 600 ml, there can be a good remission of the problems in nearly 30 to 40% of the patient. It is preferred only in patients who do not have Hunner's lesion and who have multiple glomerations, so they will get better. As part of management, very, very important to offer dietary modification. So there is a long list of what to avoid by the Global Interstitial Cystitis Foundation, as well as the ESSIC. So irritants like caffeine, tobacco, chocolate, wine, spicy foods, high potassium containing fruits, dry fruits and juices, organic or processed, preserved, sugar-free items should be totally avoided. Second thing is, people generally think it is UTI and consume a lot of tender coconut water. Tender coconut water and cranberry can aggravate bladder pain syndrome symptoms because they are high in potassium content. So please be aware that this is contraindicated, or rather to be avoided in patients with bladder pain syndrome. We've already been through this as an important way which triggers off the pain associated with bladder pain syndrome. The way we treat it is a multimodal treatment. Apart from dietary modification, we also offer them physical therapy in the form of pelvic floor relaxation, rather reverse Kegel exercises, because the pelvic floor is already taut. And they also learn what we call TL massage, where we reduce the spasm in the myofascial bands, which is done by a physical therapist or a physiotherapist who is trained in pelvic floor dysfunctional disorders. We use what is called pentose and polysulfate. It is basically a gag layer recreator, which replenishes the protective mucoprotective layer in the bladder. When I explain this condition to patients, I tell them, imagine your bladder like a non-stick cookware, which has got the Teflon coating. Now, the Teflon coating is the gag layer, which is the mucoprotective layer. When the Teflon layer is broken in multiple places, let's just like the food particles stick to the cookware. Similarly, when the gag layer is broken or there is a deficiency or a breakage in the gag layer within the mucosa of the bladder, then irritants start sticking onto the bladder wall and cause inflammation and attraction of mast cells and histiocytes, thereby causing further inflammation and triggering the C fibers. So, with regards to the diet, we are preventing any stimulus which could potentially cause destruction of the gag layer, number one. Number two, with pelvic floor therapy and reverse Kegel exercises, we are reducing the effect of such an inflammation on the muscle layer. Number three, with pentosan polysulfate, we are trying to recreate the so-called Teflon layer or the mucoprotective layer on the bladder. But this takes time, which is why the dietary therapy is very important. Step 4, by giving montelukast or hydroxyzin, which is the antihistaminic in nature, we are trying to reduce the inflammation and thereby reduce the C fiber sensitization. If they do not respond, as a step 5, we also move on to cyclosporin or azathioprine. With regards to combating the central sensitization or the pain perception, we always give them amitriptyline or gabapentin. If it is a very sharp burning sensation, scalding pain, amitriptyline is very useful. If it is a dull ache or more of a pressure-like pain, then gabapentin comes into use. This is a very phenotype-based classification of the ICBPS, where UPOINT, which is urinary, psychological domain, organ-specific, infection, neurological, and tenderness, we can phenotype every single patient based on the UPOINT score and grade them as to what severe grade they belong to as far as the bladder pain syndrome or interstitial cystitis is concerned. As I mentioned earlier, bladder pain syndrome is a multimodal treatment where we have to employ step ladder pattern of treatment. Because it's a chronic disease, by the time the patient reaches a urogynecologist or urologist with interest in female urology, patient must have seen at least 10 to 12 doctors and has been on multiple courses of therapy and nothing seems to work. All that they want is to be pain-free. So we offer them proper treatment as to pelvic floor relaxation, and I mentioned trigger point release and real massage, oral medication mainly to reduce the central sensitization pain. We also give them anti-inflammatory and then proceed to oral pentosan. If these don't work, I generally do an intravesical cocktail installation of the bladder where I use a combination of antihistaminics. I also use steroids and the heparin, which acts like a gag layer of protection, along with soda bicarb, which alkalinizes the urine, and an anesthetic agent, which immediately causes relief of the bladder pain. I tend to do it fortnightly for about 6 sittings, and the patients have shown remarkable recovery as far as the bladder pain scores are concerned. In patients who have a very severe form of OAB, which can occur in about 20% of the patients, or who have a reduced capacity of the bladder as determined by the urodynamics, then botulinum toxin comes into play, where we inject the botulinum toxin using a cystoscopic needle, both on the bladder as well as the trigone area. This is one condition where we do not spare the trigone, because the trigone has a plexus of nerves which are hypersensitive, especially in bladder pain syndrome, and the seat for the emanating pain. So we inject Botox there as well. I generally use 100 unit botulinum toxin, which is diluted and injected in 20 areas, each creating a bleb of about 0.5 ml inside the bladder in a template fashion. And if patients don't respond to that, this can be repeated once in a year usually. And if they don't respond to that and have ongoing problems, we can even consider sacral neural modulation for refractory overactive bladder, not for the pain part of it. Very, very rarely, patient might require a cystoplasty or a cystectomy or urinary diversion. We have done cystoplasty or urinary diversion in radiation cystitis associated problems rather than just bladder pain syndrome. What about the PPS, which is the pentosan polysulfate? It is marketed as either Comfura or for IC or Cystopen. It is better than placebo. It reduces the symptoms in one-fifth of the patient, and is definitely better than nothing. So 1/3 of the patient can show some remission or improvement with pentosan polysulfate. The correct dose is 300 milligram, 300 milligram whole day. It comes in a strength of 100 milligrams. So there's no point taking only one dose. It should be taken as 3 doses, 2 hours after food, and should be stored in the fridge door. Otherwise, it like some of the probiotics, it is not very efficacious if kept at a warmer temperature. Preferably to start it early and continue very long period, because the maximum effect of this medication is only seen after 3 months. So if you start it in a patient who has been suffering from this problem for nearly 10 years, this is not going to work very well. Whereas you have diagnosed it straight away, better to start it within the first 6 months and continue at least for 2 years. Just like the Dynagest, which is being used for endometriosis, it offers phenomenal relief for patients on a long-term basis, on a maintenance basis, as well as if it started earlier. We can use the combination along with the intravesical PPS, but it is not commercially available in our subcontinent. People have done researches based on it. I tend to use intravesical heparin, but I've not done subcutaneous heparin. So always, with regards to bladder pain syndrome, start with behavioral modification, give them appropriate diet modification, always start with the reduction of the central sensitization of pain, either gabapentin or amitriptyline, institute antihistaminics as part of the therapy, and if cystoscopically confirmed, do the intervention. If it is Hanna's lesion, you got to fulgurate or transect the ulcer. If it is non-ulcer glomerulation, you can do a hydrodistension with intravesical instillation and continue them on pentosan polysulfate. Always minimize the antibiotic usage and therefore maintain correct asepsis and clean hygiene, especially important with regards to intravesical installation, catheterization, so on and so forth. Thank you.
Thank you so much, ma'am, for giving this information on this topic. So let me see if we have any query in the comment section. So Dr. Indu have one question. She wants to know your views on HIFM as an option of treatment of bladder pain syndrome. HIFM, it is high intensity focused electromagnetic field.
I have no experience of using it. It is not within the therapeutic guidelines for usage. If at all, it is within the research protocol. We, as part of core faculty of Global Interstitial Society, we do not recommend that because there are other modalities of treatment which seem to be effective. So, no.
And other questions, let me see. So, ma'am, we don't have any more questions further. So we
Okay.
can wind up here. I thank all the participants for attending this session. And I also thanks to our Shield Connect team members to make this webinar possible with you, ma'am. And we will like to have more sessions with you in future.
Sure. Sure.
Thank you, ma'am.
Definitely. Thank you.